chapter of our course. It's a very incredible panel. We're here. We have a lot of people with a lot of experience, and I will present the format of our course that will be going on the following 3 months. So the first topic we are going to talk about is pediatric developmental eye pathologies. How do we diagnose and treat complex ocular malformation and inherited retinal diseases? This is thanks to the work and the collaboration and all the infrastructure that Ophthalmo University has in Latin America. And we are co-sponsored by the Pan American Academy of Ophthalmology through the Young Ophthalmologist section, which is very exciting. APEC is organizing this. Carolina, Juan Manuel, and I, we are very proud to be part of this institution, but most of all, that we have a very impressive panel of people from Bascom Palmer that work together, that has taught us a lot of how we should work in our countries. And just remember that on October 6th, we will be talking about intraocular tumors in pediatric patients from people from the MD Anderson and Boston Children's. And in November, we will be talking about ROP and to be determined the international panel. And this is very important. Why are we aiming to present this course? Because this is trying to get into the pediatric ophthalmology world. Because we know that retina is not only a retinal disease, glaucoma is not only glaucoma disease, cornea is not only a corneal disease, talking about pediatric patients. We should not be talking about leukocoria only, about a microphthalmic lost eye, a retinal dystrophy without further workup, a retinal anomaly without amblyopic management, and glaucoma only by the glaucoma specialist. How the second objective is how is it done by a leader team at the USA? How have we adapted it in APEC, Mexico? And to motivate people to start thinking that pediatric ophthalmology diseases are an entire globe pathology. And what is the future in pediatric ophthalmology with the phenotype and genotype characterization, and discuss clinical examples of all of it. This is the panel, Dr. Borokal. She's a friend and a mentor, and she's the director of the ROP and pediatric retina at Bascom Palmer. She's a vitreoretinal surgeon, and she's an expert in pediatric gene therapy. Dr. Mendoza, he's a pediatric neuro-ophthalmology, and he's an expert of inherited retinal diseases. And most of all, he's the Pan-IRD founder, which has brought all the inherited retinal diseases, geneticists, pediatric ophthalmologists, retina people together to really work hard on this. Dr. Chang, he's a leader in pediatric glaucoma, and he is at the Samuel and Ethel Balkan International Pediatric Glaucoma Center, which is the first unit integrated to help infants and children with glaucoma. This is very relevant. And my mentor, Dr. Juan Manuel Jimenez Sierra, he's the chief of the Department of Retina and Electrophysiology at APEC, and he's the expert in inherited retinal diseases. So, and last but not least, she's the one that is leading with pediatric glaucoma at the pediatric ophthalmology, pediatric retina unit. So this is what we're aiming. We're going to make specific questions to our panelists. So Carolina, can you tell us what is the relevant feature? What are the relevant features of the eye and the retinal development that explain pathologies in children?
Well, Linda, Juan Manuel, Ophthalmo University, thank you for the invitation. Please let me share my screen. Wait for a minute. Okay. Can you see my slides? Yes, perfect. Okay, so in order to understand congenital pathologies in kids, we need to understand the normal ocular development. So I'm gonna review the most important aspects of ocular embryology. I have no financial disclosures. The eye developed from two herm layers, the ectoderm and mesoderm. And there is another cell population, the neural crest cells. These cells arise from neuroectoderm and migrate from the crest of the neural folds at the time the folds fuse to form the neural tube. These stem cells make a large contribution to ocular development and key contributions to cranial, dental, and facial structures. That is why some ocular pathologies are related with some other systemic findings. At day 22, the optic placode and later the optic vesicle can be seen on either side of the neural tube. The failure of formation of the optic vesicle results in anophthalmia. As the optic vesicle extends toward the surface ectoderm, the superior and inferior walls of the neural tube constrict so that each optic vesicle is connected to the wall of the forebrain by the optic stalk. At day 27, the thickening of the surface ectoderm formed the lens placode, and formation of the optic vesicle without proper subsequent development produce nanophthalmia and microphthalmia. At 3 weeks, the vesicle invaginates to form the optic cup. The inner layers will form the neural retina and the outer layers will form the retinal pigment epithelium. The surface ectoderm invaginate and form the lens. Combination of mesodermal and neural crest cells will form the hyaloid vessels, choroid, and sclera. At 4 weeks, the fissure closes, first at its center, and then anterior and posteriorly. Failure in this process will lead to a coloboma formation or cavitary optic disc anomalies. The vitreous is formed from neural crest cells and mesodermal cells. At 35 days, the primary vitreous contains the hyaloid artery and the vasa hyaloidea propria. At 5 weeks, a series of capillaries from the hyaloid vessels form the tunica vasculosa lentis, and an avascular secondary vitreous is deposited behind the primary vitreous. At 6 weeks, the lens vesicle separates from the surface ectoderm, and the lens epithelial cells enclose the lens cavity. Abnormalities in this lens epithelium and the lens capsule results in microphakia and spherophakia. Between the 6th and 7th weeks, 3 waves of neural crest cells migrate centripetally in the space between the anterior lens surface and the surface ectoderm. The first wave is avascular and is going to form the corneal endothelium. The second wave is a vascular wave and will form the pupillary membrane and iris stroma. The third wave is avascular and will form the corneal stroma. Abnormalities in this complex process can result in Peters anomaly, Axenfeld-Rieger syndrome, or corneal pathologies like congenital hereditary endothelial dystrophy. At 8 weeks, the retina can be differentiated into an outer layer which will form the retinal pigment epithelium and an inner neural retina that commands its centrifugal differentiation into an inner and outer neuroblastic layers. This process will continue over the next months. At 8 weeks, as you can see in this image, the ganglion cells axons grow from the inner retina towards the optic stalk, and the mesenchyma surrounding the optic cup will form the choroid and sclera. At 4 months, the retinal vasculature develops from remnants of the hyaloid artery, following the same concentric pattern as retinal development. Disruption in this process lead to hereditary vasculopathies, and at the same time, ciliary processes and Schlemm canal can be observed and the hyaloid system regress. Failure in this process originate persistent fetal vasculature. At 5 months, in the anterior chamber, a continuous layer of endothelium creates a closed cavity, and the anterior surface of the iris inserts in front of the primordial trabecular meshwork. In the 3rd trimester, the endothelial membrane progressively disappears. The neural crest cells differentiate, and the peripheral uveal tissue begins to slide posteriorly in relation to the anterior chamber angle. The developmental arrest of the anterior chamber angle results in primary congenital glaucoma. The severity will depend on the stage at which the angle development is arrested. Finally, at 7 months, the outer segments of photoreceptors can be seen, the central fovea starts to thin, and at 9 months, the retinal vessels reach the periphery and the pupillary membrane disappears. But it is important to consider that cells grow, divide, and differentiate in a highly controlled manner to build a multicellular embryo. So there are early acting regulatory genes that initiate developmental processes and induce the expression of downstream genes, which will finally allow the development of tissues and organs. And alterations in this process also can result in different diseases. Thank you.
Thank you, Carolina. So, Dr. Berrocal, can you please explain us your experience at Bascom Palmer, the way you work multidisciplinary to approach all these complex malformations that, you know, AC malformations will be involved with posterior pole diseases? Just could you please let us know?
You know, I have to say, Carolina, that this topic, when I learned it or when I did not learn it in residency, it became really important when I actually became a pediatric retina specialist, particularly in the NICU, because, you know, that's the development. So you have to understand the development of the primary vitreous, the secondary vitreous. Why does it look hazy or not hazy? The tunica vasculosa, you know, so many things that, you know, I truly learned after, you know, once I was an attending. I think I really went into it, and and you show these slides, and, you know, a lot of people glance over them because it's here we go again, embryonic, you know, vesicle and all that. But it's really important, especially if you really want to understand the eye, especially the preemie eye. And I think in the preemie eye is very relevant in things like persistent fetal vasculature is super important. And Peter and I talked about Peter's anomaly, and Peter can talk about this too, you know, understanding the neuroectoderm and how these things form and why are we having a corneal opacity together with iris strands, and all these things come into play, because many times persistent fetal vasculature, when it's anterior, can also look like a Peters anomaly. So you have to learn to differentiate these things. And the more embryology you understand, I think the easier it is to differentiate these. Peter, any comments?
I just one quick thought. And like you, this is something that I perhaps have neglected in medical school. And the important thing, and Carolina, those were beautiful slides and a very systematic talk, is it kind of helps me link everything in my mind, because as you know, the disease manifestation can change as the child grows. And when you see something that's the same entity that presents very differently, if we look back onto the embryologic pathophysiology, then things start to make more sense. And in many ways, it can help us devise our treatment strategy. For example, if we have a congenital glaucoma child who happens to have a mutation that is a vascular pathogenic variant, then you can assume that perhaps that child, in addition to not having a well-formed angle, does not have downstream collector channels either. In those cases, you don't waste time doing angle surgery. You go straight to a shunt. And so I think understanding the basics becomes more important the more we dive into these complex cases.
Nina?
Yeah, no.
Okay, and now for the Carlos presentation, we have the question, where are we in pediatric inherited retinal diseases? Carlos?
We don't hear you, Dr. Mendoza.
Okay, now I have voice. Okay, thank you very much, everybody. Thank you, Juan Manuel, Carolina, Linda, for this invitation. It's very nice to be here with you guys. So I think that in order to answer this question, I prepared a few slides here. So can I share my screen? Okay, so yes, I think I can right now. Okay, good. Let's discuss a little about, where we are regarding inherited retinal diseases and also about treatment options. I think that it is fair to say that we are living a paradigm shift in the way that we understand, we diagnose, and we treat inherited retinal diseases. I think that it's important to understand how do we diagnose and how we really understand IRDs nowadays. I think that the four main pillars in the diagnosis of these conditions are the history that include the medical, the ocular, the family history, the characterization of the phenotype, how the retina looks, and how are the visual function tests. Critical is the electrophysiology, which is going to give you the objective function in the retina. And finally, the genotype characterization, of course, is one of the most important elements. But it's important to understand that you cannot make a diagnosis of IRD nowadays without the four elements that I present here. Neither one of them can do the diagnosis by itself. Many years ago, we thought that having the genotype, we're going to be able to diagnose everything, but we were far from the truth. Nowadays, we know that one gene can cause multiple different diseases and vice versa. So which are the most common IRD phenotype that we see nowadays? I prepared this slide a while ago and I like it because it is the way that I understand IRDs. I like to look at the retina histology and start thinking, by layer, which are the most common IRD phenotypes. So if you look in the vitreoretinal interface, then you have all the group of the vitreoretinopathy that include, Fever, Wagner, Stickler, Norris. Nina knows a lot about that, and I think that we're going to discuss cases. But understanding the phenotypes, what is the primary cells in the retina that is affected, and which are the genes that cause each of them, or at least the gene that we know that cause each of them is very important. And then we can go keep down all the way down in the retina, the ganglion cells diseases, also known as optic neuropathy, we know very well, and we understand the genes. And this is the way that I like to structure this in my mind. The disease affecting the bipolar cells, okay, the stationary diseases and the progressive diseases. And each of these group of phenotype, they have very well-defined genes nowadays that characterize each disease. So we can think cells, genes, and primary retinal structure. So, and then we have the dystrophies. I mean, the rod and the rod count dystrophies are probably the largest group of IRDs nowadays. That includes the typical RP, retinitis pigmentosa, syndromic or non-syndromic, okay? And we know that more than 150 can cause, for example, RP. And then we have all the other variants, autosomal dominant recessive, X-linked, and each of them associated with different genotypes. Finally, LCA is probably one of the most important in this group too. And we as pediatric ophthalmologists, neuro-ophthalmology, retina doctors, glaucoma doctors have to deal with this. Cone dystrophies, that's very critical. And we understand the most common phenotypes and the genotypes. The same for the cone stationary retinal diseases, which are not actually dystrophy. They are not degeneration, but they significantly affect the retina and they are inherited. Okay, the pigment epithelium dystrophy, the macular dystrophy is associated with the pigment epithelium disease, Stargardt, Best, pattern dystrophy, North Carolina, many of them. The one that affect directly the Brook membrane. Okay, and finally the choroidal dystrophy. So I think that this is a very good way to try to put together all the different retinal degeneration in our head. So you were asking me earlier, in one of the questions you sent me about the role of the visual electrophysiology on this. And I think that this is very important. As I mentioned, it's one of the key elements because with electrophysiology, we can really isolate through the different techniques, which is the primary group of cells that are affected. And again, if you understand the previous slide where you know where the diseases are coming from and you have good electrophysiology, that allow you to detect what is the primary site of injury in the retina, then you're getting closer to your diagnosis. And then finally, the genetics, okay? And this is a whole new chapters. A lot of progress have been made on this. And I think that honestly, we're living a paradigm shift, not only in the way that we study retinal diseases with genotypes and also how we manage them in the future as treatments. So phenotypes, the most common, RP, Stargardt, CSMB, LCA, all the N. And here just a list of some of the most common genes, USH2A, CRB1, ABCA4. So the people that follow the pan-IRD know that every week we are always, discussing about one of these guys here. okay? So this is a slide that I tried to put together to show you at least my algorithm when I think in genetic testing of IRD. Going from the top, from to the bottom, if I have a family that I know is a very well-known mutation, sometimes you only need like a single point test, and that's all you need, to characterize what the patient have. And sometimes we do this through parental or family segregation analysis. Okay, but when you have a monogenic disorder, then you see one gene, but not only one mutation, and then you can go to the single Sanger sequencing. Honestly, nowadays, Sanger was very sexy like a few years ago. Nowadays, we don't use it any longer. It's only all for 5 years. It's amazing how we're moving in this field. Once you have a syndromic IRD, I mean a retinal degeneration with generalized features, then you want to look or to open your net in order to capture diagnosis. And this is where the chromosomal microarray is very basic to understand what are the structure of the chromosome. And then, of course, you can go to the NSG, that stands for next generation sequencing. And honestly, nowadays, this is all we do, next generation sequencing. That's the most common thing. So when you have a phenotype that tells you about mitochondrial function, of course, we can do mitochondrial sequencing very easily. It's a very small piece of DNA, so we can just go and sequence the whole DNA. When you have a typical IRD suspect, next generation sequencing is the most important. IRD that you don't know exactly the diagnosis and next generation sequencing is not very clear, then you go with the whole weapons. You go with NGS, you go with mitochondrial sequencing, and sometimes we need to go for whole exome sequencing and sometimes for whole genome sequencing as we have here. The problem is, guys, that as more sophisticated you get in the genetics, you cover more DNA, but you have less sensitivity. Okay, you need to keep that in mind. Sometimes I used to use the expression, if you do like a next generation sequencing, you're looking with a microscope inside the gene. If you do like a whole exome or the whole genome, you're looking with a telescope. You may have a vision of the whole picture, but you miss small details. So it's not just to order genetic testing. You need to know exactly what you're looking for and what is the most appropriate test for what you need. And then just finally, just to tell you a little about the treatment that you also asked me your question. Nowadays IRDs have essentially 4 main streams of treatment: pharmacological treatment, gene therapy, stem cells, and retinal prosthesis. By far, gene therapy is the one that we're using the most and the one that seems to be more promising in the near future. Stem cells is also coming very strong, but the results are not yet as good as the one that we're having with gene therapy. So how these gene therapies perform, I think that Nina will explain you a little more about this regarding the one that we're doing at Bascom Palmer, but think in 4 main categories: episome, with or without mitochondrial trafficking. What do we do here? We just take a little piece of the DNA, we make it in the lab, we take a virus or a vector, we replace from the virus the piece of the DNA that caused disease, we keep the initiation and termination sequencing, and we put in the middle what we need, okay? We pack this again in the virus, usually adeno-associated virus, 2A4 chimeras. I mean, we have different options there, and then you inject that and you infect the cells and you deliver the copy of the gene you want, okay? The big limitation of this treatment, which is the one that we use the most, is that we have a limit in the load capacity of those vectors. So for example, adeno-associated virus can carry up to 4.8 kilobase. I mean, small genes, lentivirus can load up to maybe 9.5 kilobase, okay? But it's not a huge piece of DNA. Antisense oligonucleotides is also becoming very popular. Here, we do not replace DNA. We do not put a new piece of DNA. We go into the mRNA and we block the sequence in the mRNA that have the mutation, and we try to achieve a better translation. So if you're acting in the mRNA and not in the DNA, that means that you need to treat your patient several times, sometimes every 3, 4, 6 months, okay? So, but it is a little less invasive type of procedure. Usually we're doing this with intravitreal injection. CRISPR is fantastic. CRISPR is like a cut and paste when you're doing like a Word document. But in that case, then you need to keep in mind that you go exactly into the host DNA. And that's an issue, because you're actually messing with the original blueprint. So you need to be very sure that whatever you are inserting there is not causing any up or down effects in the whole DNA, particularly, oncogenic responses, which is the one that we fear the most. Nowadays, we have 2 clinical trials right now running with CRISPR technology. And finally, optogenetics, which is to transfer through gene therapy photosensitive cells, so photosensitive property for cells that are not photosensitive. Let's say that you have RP, very late stage, photoreceptors are wiped out, you cannot rescue them. So you use a channel of rhodopsin coming from an algae, and you transfer this into a virus and you put this in a ganglion cell. So now you convert a ganglion cells into photoreceptors. There are 2 clinical trials also happening on this, and there was a paper last week in Nature, with the first result for the first trial in optogenetics. So this is the universe of the gene therapy treatments. These are the clinical trials that are happening right now. In fact, there are 14. I am authorized to disclose only 9 of them right now. Okay, but we have, as you see here, several diseases, LCA. Nina will talk about that, RS1 for schisis, achromatopsia, Stargardt disease, Usher syndrome, okay, choroideremia, LHON, and some other type of retinitis pigmentosa. Thank you.
Thank you very much, Carlos. Carlos, I have a question. At this time, how many different mutations are you able to identify in inherited retinal diseases? Do you have an idea?
Well, yes, right now we have identified more than 330 mutations, but including the variants, we are close to 2,000. Okay, so if, for example, one of the panel that Nina, Peter, and I use a lot, which is the MBL, nowadays allows to study 1,160,000 variants in the nuclear DNA. This is without including the mitochondrial DNA. So, I mean, we are making progress. It's very funny because the other day, Nina was asking me, so what is the version of the MBL panel that we have right now? Because it's like almost every week we go from the 1 to 2, 3, now we're in the version 12. So this is moving so fast.
Okay, thank you.
It is, and the last question is for Dr. Chang. So I left you at the end because some people think that you just do a cataract surgery and you're done, and that's not true. Or you just do a retina surgery and just does that. That's simply untrue. Or the worst from all, glaucoma does not exist. So please explain us, what do you think about pediatric glaucoma associated to everything?
All right, so thank you very much for this invitation. I have to have a little psychological disclosure. It's very hard to feel smart whenever Carlos is in the room and we're talking ophthalmology. But so the very interesting question is, what do I know about secondary glaucoma and complex malformation? And I got a couple of slides to share. This on the left is a map of London. And I'm showing this map for a few reasons. Carolina would know this is where the United Kingdom Pediatric Glaucoma Society takes place, one of my favorite meetings. We break for tea. And every time I go to London, I'm shocked at how many train stations there are in London. It's like, why? Why can't they just build a really big one and have everybody have their trains there? And it turns out that all the train lines all throughout Great Britain have to converge onto London. And every train company wants their trains represented. That's why there are so many train stations. Glaucoma is the same. London is basically glaucoma in geography, okay? All the major diseases, malformations can eventually become glaucoma. In fact, one of my former fellows said glaucoma is the last stop before ptysis. And I thought that's pretty apt. So we have a lot to do. We have to stop the train right there and salvage the eye before the eye turns into ptysis bulbi and end up in somebody's lab. Now, glaucoma and complex ocular malformation, what do we want to know? How to diagnose it, how to treat it, and most importantly, what is the goal? How to diagnose glaucoma, this is the easy part. We no longer have to base it on vague clinical impression because a group of my predecessors sat down and put together diagnostic criteria that so far has worked reasonably well in showing how to diagnose childhood glaucoma. However, if you look at the criteria in more detail, items that relates to intraocular pressure or cupping sometimes are hard to apply to eyes that look like this. When you have a very abnormal cornea, you're going to get whatever pressure you're going to get. The tonal pen is pretty much a random number generator. Or if you have an optic disc that's very abnormal, it's very hard to notice any kind of glaucomatous changes. In those cases, if the child is young, we base our diagnosis on changes in axial length or visual field defect that's not explained by other ocular anomalies. However, a lot of these kids, we only diagnose glaucoma with longitudinal follow-up when we see progressive changes in axial length, outbound to normal age, to diagnose glaucoma. And in one of our prior studies, we have shown that serial B-scan ultrasound, looking at the profile of the optic cup, we can pick up progressive cupping and diagnose glaucoma that way. Okay, so now we're able to diagnose glaucoma in some of these very severely malformed eyes. What then? How to treat it? It's very difficult. My philosophy after first 5 years being very heroic and being beaten back into humble land is that less is more. There's always a very high surgical risk. So medication, 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 more medication. And occasionally I will be brave enough to apply some laser. But even then, transcranial cyclophotocoagulation can be difficult because we don't really always know where the ciliary body is. And that brings us to the last point. What is the goal of treating glaucoma in these eyes? Well, the goal of treating glaucoma in any eye, in any patient, is to preserve useful vision for the rest of the patient's life. Now, if this eye, by virtue of the malformation, the vision is no longer ambulatory and is no longer useful, perhaps we don't need to be very aggressive. Similarly, if the patient, due to congenital anomalies, has systemic issues such that their life expectancy is not expected to be very long, perhaps we do not need to be very aggressive. What we want to avoid is over-aggressive treatment for the number that you're going to write down in your op report and cause pain, disfigurement, and worse yet, sympathetic ophthalmia if they have a better eye. The second question that was posed to me was a little bit easier to answer, which is when do I decide that my glaucoma patient requires a team for better outcome? As Carolina so wonderfully pointed out, early onset glaucoma prior to the age of 4 is a pan-ocular disease. It affects every part of the eye, the cornea, due to high pressure and epithelial breakdown. Ophthalmos, due to high pressure, leads to strabismus and retinal detachment. And of course, there's glaucomatous optic neuropathy. And over everything, there's amblyopia. So really, you really need every member in the ophthalmology department's help to properly take care of a child. And half jokingly, sometimes even the pathologist. Here's one case Nina and I shared. It's a young man who had well-controlled pressure and had primary congenital glaucoma. And his pressure was controlled for many decades, and he came in with decreased vision. And it turned out that in his ophthalmic state, he developed a lacquer crack, and then the subretinal fluid has collected. And Nina very quickly initiated anti-VEGF therapy, and thankfully he went back and had normal vision. And I also refer a lot of patients to Carlos because I spend my day in the clinic staring at the optic disc. And when you look at it enough, you ought to find something different. And I start to doubt myself, perhaps I'm overburdening his clinic. So 2 years ago, we initiated a study to look at the yield of neuro-ophthalmic referral from a pediatric practice. And to my pleasant surprise, of the 59 patients, 42 actually require some additional imaging, which I did not order as part of glaucoma workup. And 73.1% had additional neuro-ophthalmic diagnosis. The most highest risk factors include abnormal color vision. So I check color vision on all my new patients, disc pallor and RNFL thinning out of proportion to intraocular pressure. And this is a recent patient that Carlos and I share. This patient came to me as a glaucoma suspect by virtue of cupping and pathologic myopia. And I thought there's no myopia, and that's pretty much where my intellectual prowess ends. I don't know what it is. So I always send them to Carlos to just be blessed. And he called me very excitedly and say something is going on, because he was astute enough to get a autofluorescent and show these patchy choroidal changes. The diagnosis for this patient is still pending because we're trying to make genetic testing covered. So one last point, we have to always think beyond the eyes. We never underestimate the caretaker stress. There's a high proportion of caretakers, parents to our patients who suffer from depression. And it's not something we routinely ask about. And children who have any kind of physical disability, especially those with physical disfigurement, such as in Sturge Weber, they have a much higher risk of suicide. And that's also something that we do not talk about. Lastly, low vision, any child who has poor vision, we should refer them very early. And so I start to incorporate into my team somebody outside the department, and that is a child psychologist. And we're starting a pilot study to see what the yield this might be in terms of uncovering mental health issues in our patients. So thank you again for inviting me.
This is a great talk. And I think we can discuss it with some cases that we have. Dr. Brokaw, you probably want to present some of your cases that are beautiful, and you share with all of them. And,
and can you see my screen?
Yes.
yes.
Yeah, and you can see just the slides?
No, you just have to push play.
Oh. Yeah, I got it. Okay, so you know, as we said, thank you everybody for the invitation. This is a great fact that Linda wanted to pursue this, because, you know, we do this so normally at Bascom that to think that we do something different at times, it surprises us. And I will tell you, when I started at Bascom 21 years ago, I started doing this with Elizabeth Hoda, who was Peter Chang's predecessor. She's retired now. And, you know, it started, we were in the rooms, you know, across from each other. And she's like, Nina, can you look at this? Nina, can do that? And I'm like, oh, we should do this. We should do that. And honestly, it became this really important relationship between retina and glaucoma. And then Victor Perez, who's a cornea specialist, came to Bascom. And then he started doing all the odontokeratoprosthesis, and they needed somebody to really help them place the optic in the macula. And I would sit there through 13 hours helping him, you know, like make sure that it was in the right place. So, you know, it became like a natural thing. But I will tell you, to me, to this day, it bothers me that we can separate an eyeball into so many different parts. I mean, it's just one thing. It has glaucoma, it has retina, it has all these things, and we should honestly be working more together than we do. But, you know, I think a lot of us do, and the ones who do enjoy our camaraderie. But I'll take you through some cases that show how we all interact together. And this is a 36-year-old female who presented really to Peter Chang with episodes of complete, recurrent episodes of complete loss of vision in her left eye, lasting 10 to 20 seconds, occurring 2 to 3 times daily for the past 2 months. So she comes in, hand motion in the right eye, 20/70 on the left eye, pressure of 16 on the right, but 44 on the left. So this is why she's going to Peter. And a refraction, a manifest refraction of minus 19.50 sphere. So this is her fundus. You see the anterior chamber is shallow, you know, everything looks like it's pushed forward. And posteriorly, you see that this girl had retinopathy of prematurity. She's 36. So at that time, you have to think that she was treated with cryotherapy. And you see she has a lot of ROP, and she has this elevated pressure. So history of prematurity, born at 25 weeks, treated with 13 sessions of cryotherapy by Dr. Alice McPherson, who's the first female retina specialist in the world, really. So in Texas, so very, very impressive. And she also had a scleral buckle placed and removed by Dr. McPherson. And Peter, do you want to take this?
Yeah, so this case brings back a lot of memory because it was such a big learning case. But, you know, as with all learning cases, there is a heuristics component that you're not quite sure where this is going. So you're trying to do your best and make your best educated guess. I think here our first clue was that this was some type of angle closure. And I think at that time I had not been at Bascom that terribly long, so things were not making sense. How could you have somebody who is a high myope and also be having angle closure? And more importantly, axial length was really not terribly long. And so at least for me in residency and in fellowship, we really didn't think that much about lens-induced type of glaucoma, but that was at that time the only explanation that we had. And so just to take another step back, around the time of this case, Nina and I share many different children who had ROP and retinal ablation. What I realized was that they all seem to have some kind of unusual looking anterior segment, to the point where I refer every single one of them for genetic testing, thinking that there has to be some uncovered anterior segment dysgenesis that the world didn't know about that is causing the child to be premature and have a small cornea. And Nina said, you know what? I think this is all due to ROP laser. And I start to think and I start to believe that perhaps the retinal ablation is what led to this particular set of findings. And I don't know if you have it in the slides, Nina, but we ended up calling this, there we go, this syndrome based on the finding. Pachyphakia is a word that actually Dr. Hodap made up. She said, no, this is not spherophakia. The lens is definitely not a sphere. It's thick. So it's pachyphakia. I say, okay, we do not argue with Dr. Hodap. But the other three letters, microcornea, angle closure, that was my contribution. And so PMAC syndrome was born.
And what I find it's even more beautiful is that, I've been doing ROP from the NICU to Bascom. So I follow these cases, my transfer patients. I know exactly how many times I laser. I keep track of everything. And I would tell Peter, I follow this case. This case was perfect. Suddenly the cornea starts getting iridocorneal touch in the periphery. It's a little weird. I would show it to people, cornea specialists, adult cornea specialists, like, I don't know. Then the cornea would start to compensate. I would show it to cornea people. No, I don't really know. And, it wasn't until Peter and I started working together closely that Peter goes like, there is something. I'm like, Peter, there is something. Let's look. And every patient that would come that looked funny, I would send it to Peter and back and forth. And this is the result really of working together, because I will tell you, retina people who do ROP, they treat it and they never see it again because it goes to the pediatric ophthalmologist. But because the kind of practice we have at Bascom, I follow these cases, so I know exactly what I did and how they looked, and I photograph everything. So luckily, Peter came up with this great idea because of this case, and we went back to the retrospective review, and we realized that this is a real phenomenon that happens after you ablate the periphery in these cases. So the pathophysiology, retinal ablation causing decrease in anterior segment perfusion, mild development of the cornea and the ciliary body ring, creating soneural laxity and pachyphakia. And the myopia is not really axial myopia, it's really lenticular myopia caused by the change of the lens shape. So Peter, you want to take the management?
So yeah, and this is something of a paradigm shift still, glaucoma specialist, my initial thoughts was trabeculectomy in adults, tubes in children. Those were the only two options, especially the angle was closed. And I had several bad experiences with PMAC patients because one such experience was a trabeculectomy, and I just could not keep the anterior chamber formed on the table. And one of the more difficult days that I had. And tube shunts is equally problematic because the anterior segment is so small and the chamber is so shallow, inevitably the cornea will fail. And circling back to my mentor, Dr. Elizabeth Hodap, who really is the nidus that inspired us all, she said, well, why don't you take the lens out? I thought, but the lens seems to be working okay. And her reply was, it's easier to change the lens than to change the cornea. I thought, makes perfect sense. And at that time, the EAGLE study in adults on lensectomy and angle closure was starting to make waves. So I thought, let's apply the same principle to these group. And so we start to default these children on lensectomy and gonioscopy lysis and fixing whatever else that needed to be fixed, and compiled a case series. And actually it seemed to work reasonably well, and certainly much, much safer than either one of the options in terms of trabeculectomy or a tube shunt.
So since we're here, this is, we work together. So I did the vitrectomy. Let me stop this for a second. So I did the vitrectomy, making sure in these eyes that are so delicate that you're removing as much vitreous as you can. I don't necessarily want to lift the hyaloid because, you know, that interface between the normal retina and the cryo scar or the laser scar is so tenuous that you don't want to be anything forceful, but just to bulk the majority of the vitreous to be sure that you don't have any traction. And then I always like to do another laser of a row of laser just to be sure it's fine. And I will always at the end go to air or probably air. But then this is Peter's part, which I think it's neat. Go ahead, Peter.
So the key is to have really good visualization, and more importantly, to really stay calm, because I think a lot of the time the surgery is moving very quickly, and here I really want to be in the zone, and the key is to pull on the iris very gently. You know, the thought I try to impart to my fellows is let the iris open up on its own. You're just guiding it. And so here we're very gently teasing the iris away from the angle. And you can get a clue as to whether or not the underlying trabecular meshwork is functional based on how pigmented it is. If it's relatively non-pigmented and the iris comes up pretty easily, especially if the pressure only went up within the last 6 months, usually the procedure will work very well. And this is sometimes can be supplemented with additional goniotomy if after pulling open the iris, you see the trabecular meshwork being very pigmented.
Yeah, and the interesting thing about this case is that we fixed one eye, and I swear, like the week later, she presents with the same thing in the other eye, and we had to do the same procedure in the other eye. But she's super happy. She's like doing really well. The pressures are controlled. She's seeing well. The retina is stable. So, you know, PMAC is a real thing. You should look at it and think about it when you see them. And I agree with Dr. Ho that changing the lens is easier. We have one case that we had to do a corneal transplant. She's doing well in that eye, but it's not her main eye at this point. So you try to prevent getting to this point by doing a lensectomy. So our second case is a 5-year-old seen every 6 months. It's the age of 6 months because of some nystagmus that they had recognized by pediatric ophthalmologists and sent to Bascom Palmer directly to Carlos for an ERD for a possible IRD. Carlos, you want to take this?
Sure. Yes, I received this patient one day, so I took it to the OR to do our usual evaluation under anesthesia protocol that includes not only ERG, but we try to do everything at one time. You know, we try to do keratometry, we want to do refraction, we want to do FA, OCT, everything, okay? And sometimes the blood for genetic testing. And then when I start looking at this side, I say, hey, this is not an IRD. I mean, there is some change in the retina, but what's going here in the periphery of the retina? And then being on the ER, I call my dear Dr. Berokal hotline, you know, Dr. Berokal, 911, and say, you know, I think that I have something here that belongs to you, not to me. Okay, and you better take a look on this. And I say, okay, got it, finish it, send it to me.
And what was interesting, Carlos, if you remember, they thought that the patient had IRD because the refraction was changing, right? That's
correct. That's correct. But the retina was not IRD at all.
Yes.
And then also, you know, the bilateral changes, the exudation was quite different from one eye to the other. So you have asymmetric IRD, but not that asymmetric, only in exceptional cases.
Correct. So, you know, Carlos called me, and then we go to the operating room and we do an angiogram, and here you go. You have all these dragging of the retina with a vascularity 360, and the left eye, you have a very significant avascularity with leakage in a very particular finding. So, you know, I talked to the mom is Cuban, the father is Jordanian, the father has another child from another marriage, and together they have this kid and they have a girl. So we do genetics. Well, we treat it, you know, I do laser. When I do a lot of laser, I like to do an STK. I don't like to start with Avastin because many times it crunches the retina and it detaches. So I like to start with laser and see how the laser goes, bring it back in 6 weeks. And this is after the first treatment. It's still holding nicely. So we go again and we treat some more, and then we can inject Avastin when we know that it's not crunching badly. But this is a case of NDP mutation. It's in the NORI gene. It's also, think of X-linked fever. So we know that the mother is the carrier, the daughter is not going to manifest it, and the son is going to get it. I see a lot of these cases, unfortunately. I can think of a lot of families, but the beauty of this is that you see how we all work together. And now, she understands her mutation. Carlos can sit with her and talk about it, and then I can treat the retina. And then we can test if she has more children, then she knows, and we can move forward. Carlos, any comments?
No, I think that, Nina, this case illustrates very well what you told me at least maybe 5-6 years ago when I was in the cafeteria bus compartment deciding whether I decide to leave New York to Miami. And Nina told me, you know what? You belong to this place, and we really need you here to keep assembling the pediatric ophthalmology group. And she was prophetic. I've been enjoying every single day of being in Basel, working all these fantastic guys, that I have the privilege with. So that's the bottom line.
So we'll go to a third case, and this is a 12-year-old girl who presents with decreased vision to my clinic in the left eye, 20/15 on the right, 2200 on the left, pressure is normal, with a left exo. And this is what we see in the left eye. So here I am, I look at this and we all think the same thing. Could this be, Wyper Mason? Could this be, something else, but it screams Wyper Mason, right? So we do an angiogram and look at that. I mean, that is like a beautiful, beautiful picture, completely pathologic. And I obviously call Carlos. Hey, Carlos, I need you. So we send it to Carlos, and Carlos goes ahead and does an MRI to be sure that there's nothing in the brain. And Carlos?
Yes, I remember that this patient was telling us that she was having some pulsatile tinnitus, some whooshing sounds. And that is one of the few things that an ophthalmologist uses a stethoscope, just to try to do an auscultation. And then, and it was positive. And I said, there is something else here. So we moved ahead with this MRA. And then you can see in this axial cut in the left orbit on your right, you see something in the orbital apex, which is an AVM, which is an arteriovenous malformation. And this is better seen here in the right portion of your screen, which is like, you see this number of blood vessels over here in the projection of the middle cerebral artery. Well, this is the AVM. So we confirmed that the patient had an AVM. We were concerned about, increasing intracranial pressure, but more importantly, we were concerned about subarachnoid hemorrhage, and then we refer this patient for our interventional radiologist team to work with that.
And one of the things, cases come in pairs, sometimes in threes. So obviously I had another one that show a lot of peripheral ischemia. So many times what we're diagnosing in these kids is that not only do they have Wyper Mason, many times they come ischemic. And that ischemic retina, as we know, will always do funny things, and you need to treat it. And, I think we haven't treated Wyper Mason, but I have another kid that comes from elsewhere that has it. And it's been very aggressive, very difficult to treat. And Avastin injections, laser, and Kenalog actually works well. But this multi-specialty thing that we should be doing more often, it helps us think of diseases in whole different ways and management appropriately. Because Peter, with PMAC, we have changed the way we treat these things. Wyper Mason, me and Carlos had decided, well, this avascular retina has to be treated. So we are changing the way we're managing kids. And, now we're doing more angiographies, more genetic testing. So all this field of pediatrics is changing very rapidly.
Well, I will interrupt you because I want you to leave your fourth beautiful case at the end, Dr. Brocal, so everyone stays. It's a beautiful gene therapy case. But I have a lot of comments and questions, but the three cases that we're presenting on our experience where we are trying to replicate what Bascom Palmer does, and we're doing it at APEC in Mexico with your training. And this is basically what has changed our thoughts. And this is why Juan Manuel is also here, not only because of his experience on IRDs, But because he has this thinking process of an adult, of how you treat retina and how do you treat glaucoma patients. And this is how we decided to treat this patient. So could you please stop sharing your
Yes, I can. I think there.
So this is case number 1. So this is a 21-year-old female, and even though she's now older, we know that she has a disease that is caused in a younger age of hers. So she has a previous diagnosis of closed-angle glaucoma, and they did a peripheral iridotomy, and she was treated with brimonidine, durzolamide, beta blocker with oral acetazolamide. And she had a vision of 20/60 and 20/70. She's a patient of Carolina, and the IOP in the left eye was 24. She was not myopic. And I want to make a point of myopic patients that you mentioned earlier. In our experience, even though it's not long, we have already faced some patients that people are following patients with progressive myopia, and this is a very important point. You have to start thinking on glaucoma when you have a very progressive myopia, and this is very important. So she had surface disease secondary to all the drugs she was receiving. And Carolina, I don't know if you want to explain these pictures.
Yes, we made gonioscopy, and as you can see in the pictures, the angle was almost closed. There's only some small places where you can see the scleral spur, but generally it looks closed, both eyes. And the anterior chamber was flat, and there is the LPI that was previously performed before the referral. And this is the other eye, also with angle closed. And this flat anterior chamber. And what surprised us is that, I don't know if you can see clearly, there are these changes on the posterior lens capsule that was related to firm vitreous adherence to the anterior hyaloid. And when we went to see the optic nerve and the retina, she had a very cupped optic disc. It was worst on the left eye. But what really surprised us was these retinal changes, these retinal pigment areas, these like she had some fluid. So one of my fellows was the one who noticed it, and she decided to study a little bit more until we waited for Linda to look at it.
Yeah, so this was without an OCT, I was not sure if it was the ILM or if it was something else shining this way, because it didn't look like an epiretinal membrane. It looked like an inner anomaly of the inner retina. And this is a wide, an ultra wide picture of the retina, and we found all these peripheral changes. And the autofluorescence, I'm not displaying it, but showed atrophic areas, hypoautofluorescent areas, and it was a very advanced disease. But this is the macula I want to discuss with Dr. Mendoza and Dr. Juan Manuel. What do you think about this macula?
Well, there are some cystic changes in the central area of the macula, and there is also a hyperreflective lesion under the retina. But the clinical picture also showed the loss of the internal limiting membrane and some yellow lesions in the retina, but not typical of any other disease. Can you return to the?
Yeah, I have a better quality. This is the referral one, but you want to see the picture?
Yes, the reflex of internal limiting membrane is abnormal for a 21-year female. This is not caused by the glaucoma. Something else is happening with the retina, but we need more studies to find out the diagnosis. What do you think, Carlos?
So I think that this is an esquisite-like type of lesion, okay, that is causing a splitting from the photoreceptor into the middle layers of the retina. I mean, the white deposits are not typical for some of the most common diseases, and for sure the optic nerve cupping is a little odd. So I don't see so far here the association, but we need to get more information.
Yeah. So Linda, any kidney problems or no?
No. She's systemically healthy, apparently. We sent her to genetics, but they really didn't find anything. But this is the visual field. I would explain that it's damaged. I don't know if Carolina wants to say more, but
she has a severe glaucoma damage on both eyes, but it's worse on the left eye, which correlates with the clinical picture and the OCT, and also with the baseline IOPs that was higher in the left eye.
So this is the measurements. The AC dentate chamber depth is 2.44 and 2.55 on the left eye. The lens thickness is 4.13 and 4.18, and the white to white distance is 12. And
I'm sorry, Linda. We ordered those measurements because we wanted to understand why she had angle closure glaucoma. We wanted to be sure that it wasn't a short axial length or a thick lens or a small anterior segment. That's why we ordered the white to white, because clinically we saw a shallow chamber and a closed angle, but we quite didn't understood what she developed that. She wasn't hyperopic, she was a little bit myopic, and the axial measurements were normal.
And this is our OCT. So what do you think now, Dr. Brocal, Dr. Mendoza?
Well, that to me doesn't really look like schisis, like, you know, nothing like exsynchronous schisis or anything like that, because it's so contained to the foveal margin. You obviously have something at the RPE level, subfoveal in both eyes, and you have almost like a CME picture in both eyes. I don't see any connection to the optic nerve. Sometimes when you have optic pits, you see like tracking from the optic pit, and you can have edema at different levels, even subretinal, intraretinal, but unusual. I would be interested in genetics, really.
No, absolutely. And I think maybe from the medical history, it would be nice to have more element. Do this patient have any articular disease, any joint disease? Okay, do this patient have, as Nina mentioned, kidney disease, any lung disease? I mean, we probably this could be one of those syndromic more type of patient, you know, because it's not typical for X-linked retinoschisis either.
Okay, well, the genetic workup and the systemic workup so far, thus far is negative, but this is the UVM where you can see the thinning, and the provan is the only affected member in the family, and this is the autofluorescence. So any different thought here?
It has more of a CME kind of picture, you know, the petaloid, description of macular edema.
So my question for you, Linda, is which kind of genetic testing you get? So which type of gene are you studying? You know, where are you aiming to, you know?
This is very important, and I actually wanted you to discuss it because we don't have the availability of your testing. So we kind of rely on our genetic testing that includes some vitro retinopathies. And we have a fever panel, and we have a cone rod dystrophy panel, and we have a collagenopathy panel, but it's probably not the largest. Even though we have some limitations, we did have some results altered, and I would like you, if you could discuss about it. But this is something interesting. Now that Carolina and I were working, we have found too many angiographic anomalies that sometimes it's just very perturbing not to know whether it's a real retinal disease or everything is just caused by the glaucoma. Because look, we have this. So we have leakage in the periphery, we have some avascular areas of the retina, and the more and more we do these studies to glaucoma patients, I know that Dr. Brocal and Dr. Chang reported about the peripheral anomalies in glaucoma, But what about this patient that does have a macular disease and cystic changes and a fluorescein that does look like a petal macular edema? So
Linda, I just have one quick question. Were the pressures high in this kid all throughout in this child? The pressures were high.
Yes.
Always
The baseline pressures were very high. She was referred to us treated with topical hypertensive drugs and acetazolamide. That's why during the first IOP readings, pressures were in the mid-20s, but baseline IOPs was around 40s.
And did you ever have vitreous cells? I'm just curious.
No.
Well, the OCT shows something in the vitreous going on. If you go back, Linda.
Oh, you mean if we had something different, like
yeah,
vitreous cells, like vitreous cells.
Yes, and actually, when I saw this patient, yes, Carolina, we thought it was a uveitic patient, and actually we thought it was only pigment, not.
Carlos quiere ver
Because I wonder, just throwing you this out there, I wonder if this could be like a very low-grade pars planitis.
She didn't have like anterior uveitis nor a cyclitic membrane, just this mild.
Have you treated this with Subtino's Kenalog?
No.
But wait, we will have an answer for you there.
Okay.
Well, because actually we had uveitis got involved, and they thought it was not uveitic. We thought it was something dystrophic, and that's why we ordered a panel, and we still have many questions. So
I see several things here that call my attention. The very first one are those vitreous changes over there, the schisis and the peripheral, vascular disease you're having. If you put all these things together, vitreoretinopathies in general have to be higher in your differential. Okay, it's not typical for any of the one that we discussed, but remember we have several phenotypes. Okay, and that Nina is the one that probably can tell us the most. Regarding, which kind of genetic disease you use, that's a big issue right now. If you ask Nina, Peter, and I, probably each of us have our favorite panels that we go through. Why? Because they are, focusing the kind of thing that you need. Okay, and here we have everything. So we have panels that are cheaper, some of them free. There's few genes, and then you have some that you have to pay for and test for a little more. It's not only the number of genes, it's also how many deep intronic mutations, how deep in the introns you go. That's another thing. And how many times you pass over the same section, which is the one that gives you the sensitivity of the genetic testing. So I think that this is an IRD. It's too symmetric, it's bilateral, it's too symmetric. So,
and look, this is for you, Dr. Mendoza.
Well, I mean, this is a best one. Well, all of them are percentage significant. So this is the typical panel from Invite, 293 genes. Okay, this is a good panel, especially because it's free. And then you don't have introns, you don't go too much into the introns, and it's only one single pass. But anyway, none of the genes that you have here is pathogenic at all. All of them are BUS. And BUS is more or less like idiopathic in medicine. We don't know exactly what that means, and we're idiots. And sometimes we really need to get into the gene, forget about the ulcerative significance, and take the amino acid substitution or the nucleotide substitution and go to the probability maps. And we have several databases that are free. And you go there and try to see which are the probability for this substitution to be pathogenic. So I don't think that the best one represents anything here. Honestly, the phenotype doesn't fit. The family history doesn't fit here because we don't have a dominant pattern. Am I correct? You always be thinking like a de novo mutation, but come on, it's not that.
But I would say two things about BEST. And Carolina and Linda, correct me if I'm wrong, but I've never seen BEST with edema of the macula, like that pattern. And the second thing is that I never trust the family when they tell me they don't have anything. I do OCTs on everybody I think they have BEST, because let me tell you, I've diagnosed lots of family members that tell me they're perfect and they have best. So I don't believe it unless I see it under an OCT machine. So you know.
One thought I want to share, of all the genes that are tested on this screen, best one is the only one associated with early onset angle closure glaucoma. I know we neglected glaucoma for a little bit because retina is very pretty to look at, and I enjoy the discussion. But if you look at what's rare about this case, the retinal findings are striking, yes, but young people don't get angle closure. And the thing about glaucoma is that the panel assay only has 37 genes. We don't know that much about early onset glaucoma. So that might be a high yield place to start looking at. Of all these genes, because I use this panel a lot, the only one I recognize it, which happens to be angle closure glaucoma, is best one.
Yeah, but I will tell you, Linda and Carolina, I want you to OCT the parents. You have to OCT the parent. Trust me on that one. Do not trust any parent who says, I'm fine. That never happens. You have to see it. And then if you have something, then I'm going to believe that this could be best.
I love Peter and Nina, but I don't think it is best. I mean, this macula is best.
I mean, it's totally, but you know, the other thing, Carlos, that we never talk about, and is that this is a panel of only 293 genes.
That's correct.
It could be another gene that's affected the presentation of the best that we don't know about. You know, and this is what we're starting to realize in all these weird presentations of genetic disorders.
I agree. Well, I would like to say that I agree with Nina. We do not see cystic change inside the retina in Best disease or vitelliform dystrophy. So the clinical is different than the genetic in this case. So we do need to study more this patient to finally get a diagnosis.
Yeah. We have our geneticist and our team working on this. She actually asked us to stop and hold on the results. But we wanted to share because it's something very interesting, because we have a patient with this panel, a patient with vascular disease, pigment in the anterior vitreous that doesn't look like an uveitis. We don't have any uveitis stigma. So again, working together gives us better results. And Carolina, maybe you want to talk about what you did.
Yes, I want to make emphasis on the teamwork for these cases, because the surgical approach were really discussed between all of the doctors that saw this girl, and even with Dr. Chang. He has been helping us from Bascom Palmer. So we decided to treat like an angle closure glaucoma. We decided to take out the lens, try to do goniosyncytialysis, but I was only able to open the angle 90 degrees. And I decided to do an endocyclophotocoagulation to help us lower the intraocular pressure and try to get rid of the oral acetazolamide. And these are the post-operative pictures. 1 week after the surgery, we placed an intraocular lens in the back without any complication.
This is something Dr. Brocal will like. She was treated afterwards with steroids for the post-operative management, and the macula improved. So we will, in another meeting, probably tell you what's going on with this patient. But this is how you have to think. And the second case, I'm going to skip this because I want you to present the gene therapy case, and I think our discussion is very, very interesting. But this is a case I want you to see. Here. So we have a patient also that comes first to Carolina. And this patient is coming for a second opinion. She has low vision, she has migraine. And when she comes, her vision is count fingers. That improves with her correction because of a very, very high myopia. You see, she's minus 24, minus 30. And she improves to 20/70 and 2200. And the IOP is very high, it's 30 and 27. So someone has also done LPI elsewhere. And she had a very
Shallow.
shallow AC, and this is the lens. So, Dr. Chen, what do you think about this?
So there are a couple of things that you see on the slit lamp and you just feel a chill down your spine. I think this is probably one of those. The first thing that you notice, and it's a gestalt that I finally acquired after some time, is that the corneal diameter looks small. That's never a good sign. And the second thing is when you can see the lens edge after dilation, that's also never a good sign. And so without the benefit of a optical section or a scan, I'm going to venture to guess that this is a spherophakic patient.
Yep, so the patient was having a microspherophakic, and this is the optic nerve. I'm just saying that it's cupped. I believe, Carolina, you stated it's a 10-10 total coping. And this is the UVM, also with a very shallow chamber and a thick and short lens that corresponds to the microspherophakia. And Carolina, help. So
yes, we have a severe glaucoma damage in both eyes. And as you can see here with the visual field, really, really depressed visual field. The right eye was the best eye and the left eye was the worst. So regarding this case, the glaucoma mechanism in these cases is that there is a forward movement of this spherical lens due to the loose zonules are sometimes the subluxated or dislocated lens that you can find in these kids. So there are two mechanisms. You can have the pupillary block that was treated with the LPI, but also you can have a chronic angle closure glaucoma, meaning with a progressive synechia closure. So we decided to do a lensectomy, not placing an intraocular lens, because if we place an intraocular lens, the procedure, the forward displacement of the lens, we will worsen the angle, and the angle will keep on closing. So we decided to perform a lensectomy and endocyclophotocoagulation, and you're going to see in the next video the findings that we saw at the peripheral retina. That's why Linda also was integrated into this kit treatment.
So what we did a combined surgery. We decided to address both of her possible and current problem and possible future problem. So I placed a buckle. I do scleral tunnels, as someone taught me. So I love to do this, and I'm not sure if this causes or improves or do something to glaucoma. I don't believe it. Dr. Brokaw has done it for several years, and it doesn't really change the glaucoma outcome. So I placed a band, and I always do transillumination to place the scleral tunnels. I never go with the measurement. I do transillumination. And we had this, so I was playing with the OCT just to do how the lensectomy, and our resident, he funnily, he says that it's a lensectomy because the OCT, so it's fun. He made a video out of it, and he made this video. He actually edited it. And look, I want to show you how the 360 lattice was seen, nice pain. And I have a question here, very important. When do you address the posterior hyaloid in your patients? Have you found that lifting up the hyaloid on the long term changes your glaucoma outcomes or not?
Well, assuming that this patient will eventually need a tube shunt, not having vitreous there to plug that tube will keep the tube working longer. So yes, and I always am appreciative in all of Nina's gifts of cleaning out just every last bit of vitreous, so I know that my patient has the best shot.
You know, I have to say that, you know, I think you should remove it if it comes easily. Peter and I have a lot of cases where we're doing a tube together and I can't lift it, and I will tell him, listen, make that tube long, put the bevel up towards the front, and put it so we can see it, because I can't remove it all. I mean, I will tell him. And it happens a lot. I mean, you can spend there a lot of time and you're gonna create more problems, and then you're gonna have an aphakic kid with a tube and a retinal detachment with oil or gas. I mean, so I do believe that less is more. You know, you do as much as you can, but you're gonna have to follow those patients. And as soon as that vitreous clogs the tube, or that vitreous sometimes comes forward, you might need to remove it. But Linda, I think we have to make a point, and Peter and I were talking about this, of the importance of placing a buccal in these cases that we leave aphakic, that have trauma, that have sticklers, sometimes even Marfan's. I mean, they're very hard cases to treat later. And once you have that plate, you can't buckle them appropriately. So Peter and I struggle with this all the time. And my take is what you did here. Place that buckle. You know, it's so easy to do.
Okay, and Juan, what do you think about this on the adult retina perspective to treat a kid like this?
Well, we always try to remove the hyaloid, but as Nina said, the case is very difficult if we try to remove the hyaloid, and it's difficult. Sometimes it's better to stop the surgery and no more surgery. I agree with Nina.
Well, in this time I decided transsurgically to lift the hyaloid, and actually it was not as hard as some other hyaloids, but just very hard. And I actually lifted up a little bit anterior to the ridge of my buccal, and I lasered 360 all of the lattice. And I think we are very happy about the outcome, because this kid, she's let me wait. Her IOP is partially controlled. She's again under drops, because Carolina decided to do here with her fellow. They did an endocyclophotocoagulation, and you can see how the ciliary body retracts. Maybe Carolina, you want to talk about this?
Yes, we tried to do ECP at least 180 degrees with direct visualization of the ciliary processes, trying to open a little bit more the angle and decrease the aqueous humor production, and maybe it could help us. And today we saw this kid. She's 3 months post-op. She's on 3 drugs on the right eye, and IOP was 18. And on the left eye, she is on 1 drug, and IOP was 11. So it worked.
And the vision is great. She's very happy.
Yeah, her
so,
vision.
And it's not. We were not only playing with the OCT. It's actually showing how the angle opened up after the surgery, right after the surgery. So it's
But you see, what this case shows to me is that we have to think about these kids completely differently. This is not an adult retina. The buccal early helps. The way we think about it in a stepwise fashion, and working together to keep these eyes really seeing long term, I think it's the way to go. You cannot treat them like adult retina cases. Very different.
Linda, what about the other eye? Are you planning
we did the
surgery?
same thing. We did the same thing.
We did the same thing, both eyes.
Yeah, with about 3 weeks difference.
Yes.
More. And Dr. Brocal, you probably want to show your gene therapy. And before finishing, I just want to thank my fellows, but I will show the picture at the end.
Nina, we cannot hear you.
So, Linda, in this patient with the schisis, did you perform electrocardiogram just to see whether this is a pigment epithelium disease primarily or not?
The EOG is totally flat. It's abnormal. It's
oh, the EOG is abnormal.
Yes,
Okay.
I showed it. I went fast, but it's abnormal.
Okay, that's really then support best as a possibility.
Yeah.
Okay, can you hear me now?
Yep.
So 5-year-old African-American girl diagnosed with biallelic RPE65, vision 2150 on the right and 2070 on the left. This is the eye, and you can see there's some vascular attenuation, and there's so RPE mottling all over the retina, and this is the left eye, same thing. And because it is a biallelic RPE65, Luxturna is approved to treat these eyes in a subretinal fashion with voretigene, which is the RPE in an adenovirus form. And here I am injecting it after I removed the hyaloid, elevated the hyaloid. I'm injecting it in the subretinal space, and we inject 0.3 mLs. And the idea is that you want to do it in one bleb, but many times if the fovea, if it becomes too high, it can get too thin and create a macular hole. So it's better to do 2 or 3 or 4 blebs, better than do one that is too high and too thin. Also, Carlos and I started, he came up with the idea of injecting it nasally too, because that increases the visual field of these patients. And injecting it nasally has worked well in a lot of these kits that we have done. So here, I'm still injecting. I have a flat contact lens that for me works well because I have a good depth perception of this. And you do it automated with the machine, and you do it slowly until you feel there's a fovea. We detach the fovea in these cases. You don't have to. You can get close to it, but if it comes, and then you just let it be. You will see that it's just, we do it until we inject the right quantity. And here is the OCT showing that we detach the fovea, and it's nice to confirm the location of your bleb with the OCT. And you can see that there's a nice big bleb in this child. And we're doing this with 3D surgery, which was very nice to do. This is post-op week 1. The vision drops a little bit. You see that there's air. You leave air in the eye, and you have some Kenalog in the eye. This is 3 months out. The vision's back to 20/70 in the right, and the left is doing well. And this is the OCT at 3 months, and you can see that it looks pretty good. Not too much destruction of the RPE. In some of these cases, the RPE can get damaged from the lifting of the bleb. But when Peter comes along, I don't know if Peter, you remember this, you know, I do subtenos Kenalog in these eyes, and they're also getting 1 milligram per kilogram of steroids, PO, to control the inflammation. And sometimes you feel that the medication goes over the retina, so that's why you do an air fluid exchange to remove as much as you can from the pre-retinal or vitreous leakage of the medication. So you do your air fluid exchange. And then you do subtenos Kenalog in kids because they're inflammatory, and the 1 milligram per kilogram just for 3 weeks while you do 2 eyes. You have to do 2 eyes within a week, ideally. So the pressure kept going up and up and up. So I'm like, I started COSUP, which I can do as a retina specialist very happily. And the COSUP did not do anything, and the eyes are red and she's uncomfortable. So I go, Peter, I need your help. So Peter, take it.
So yeah, I was initially a little bit surprised at the amount of steroid that these young children after gene therapy gets, but that is their best shot, so we need to support it. And thank goodness, most of the time these cases, the pressure will resolve pretty easily. Most of the time it's due to steroid response, and as you can see from the previous pictures, they usually have very healthy optic discs that can take pressures in the high 20s, sometimes even 30s, for weeks at a time without acquiring any optic disc damage. So we can monitor them frequently and not get too nervous. Netarsadil works remarkably well for steroid-related ocular hypertension. The exact mechanism is not known, but that has become one of my early go-to medications for these cases. The couple of times when the pressure will not come down, not necessarily with gene therapy, but with steroid, a beautiful surgery to do is to do a circumferential trabeculotomy ab internally using either a Prolene suture or illuminated microcatheter. For me, that procedure has a success rate somewhere around 85% of getting the medication, getting the patient's pressure control without the use of medication. And so that is something kind of a plan C in case medication and steroid washout does not work.
And Peter, do you have a feel between the ROCK inhibitors, between Rupresa and ROCK-LATAM? ROCK-LATAM is nitazoxanide plus Salatan, right? Is there?
Yeah, so, you know, as you taught me, I try to avoid prostaglandin analogs in postoperative retinal patients because of the potential retinal side effects. So I typically, and for a lot of these children who need short-term medications, I have a tendency to lean away from fixed dose combination because you've got to titrate them off of medication once steroids washed out. It's easier to take away medication one at a time when you're not combining the same bottle.
Great. So, you know, at post-op month 5, 2070, IOP normalized, we stopped the IOP medications. And the amazing thing is that this kid is doing well. I mean, I will tell you, I've done, I think like 12 or 13 Luxturna cases, Luxturna kids. And I will tell you that to this day, I'm very impressed. And that this is even one of the most impressive thing, you know, you see these kids functioning well, but we can't sometimes measure it. But Carlos has been able to do it. Carlos?
Well, and this is an ERG. This is just a photopic and macular flicker ERG before and after surgery, pre and post. And if, I don't know if you can see the values here, but this is a kind of ERG, the pre-op, that you can only do on the anesthesia because the amplitudes here are 1 microvol and 0.6 microvolts. There is no way to have this in clinic, but only in the OR with a very relaxed kid, you can have it. And see how this ERG amplitude goes all the way from 1 up to 30 something microvolts and 20 something for the flicker. So this is like almost like a 300% increase of the electrical signals coming from the retina. And it's the objective confirmation of the subjective improvement that most of these patients refer.
And to really confirm this is my favorite thing. And this is one of the kids that we did. And in the video on the left, he's covering the operated eye. And you can see that he cannot move at dusk. And this is 7 days after I operated on one eye. He uncovers the eye on the right and he's running all over the playground. So to me, as a mom, as a doctor, as a surgeon, this is what gene therapy is all about. To have your child, you know, be able to be a normal kid, there's nothing more amazing in my mind. And I think this video shows you the impact that gene therapy can have.
Nina and Carlos, I have a question. This is a wonderful result, but I do not understand. When you inject the Bordet's gene, the Luxturna, under the retina, are you modifying all the retinal cells or only the cells located under the injection bleb? Carlos is showing an increasing in the ERG response. How can you explain that?
Well, I think that this is an excellent question. The very first thing is the very straight answer is we don't know. We don't know how far do we go with this subretinal injection because as Nina showed, initially we create blebs, but those blebs last maybe 24, 48 hours. After that, there is no bleb. So where all this product is going, I support this all over the retina. Most of these RPE65 kids, as Nina mentioned, we place several blebs and we try to cover all the paramacular area where our highest concentration of rods is located, okay, which is around 20 something degrees outside the macula. I think that what we're seeing here is the return to the function of cells that have been dormant or have been dysfunctional. And when you give them, you know, the product, the gene that is converted in the isomerized enzyme that is again able to convert all cis to trans retinol, then you restore the visual cycle. So I think, Juan Manuel, that this is the explanation that you recruit more cells that are coming to function that they weren't. And I think that this is the translation of the ERG. And you know, at the beginning, we did this very skeptically. I remember that in the first case, patient were saying, Nina and I, you know, we're seeing fantastic. And Nina I said, no, that's not possible. It's only 3 days, you know, 1 week.
Listen, no, Carlos, not 3 days, 24 hours later, I had mom texting me and I have all these texts. Doing much better. There's less light usage. And I'm thinking, impossible. This is like good, you know, wishful thinking from mom, set it up. But every one of these kids that I've done, 24 hours that nobody can understand, 24 hours we see changes in function.
And the other important thing, Juan Manuel, is that the youngest the kid, the better response we have and the better the ERG recovers. I mean, this ERG is far from being a normal ERG. We know that. I mean, a normal ERG at this age could be maybe 400, 500, 600 microvolts. It's not there, but it went all the way from 1 microvolt to 30 something microvolts. And I think that for kids, that's a lot, you know? So it's objective. The only thing that I can tell you that it's objective.
Wonderful. Are you injecting patients without ERG response?
Yes, we have. I mean, we are not doing ERG in all of them, and the main issue is moms that don't want to put them to sleep again. Okay, so remember, we need to do this under sedation, and at the beginning, pre-op evaluation, everybody wants to do it, but after that, I will say maybe 50% Nina, 40% of the family are able to do it. But we have at least, you know, few patients where we have been able to have the ERG and they all show some degree of improvement. The oldest the patient, you know, I repeat, the less the response.
Yeah, I think of the ones that I've done, I did a 19-year-old. And even the 19-year-old, I'll tell you, it's impressive because I knew this kid since he was a little boy. He was always very depressed, very dark. We did the surgery. He came after the surgery and the mom said, the only thing I noticed is that the light in his phone has gone down, you know, the amount of light he needs to see. When he comes 2 years later, okay, by himself, he's happy. He has a job. I've never seen him smile in all the years that I've known him, and his vision improved. So it's honestly, to me, it's very impressive.
That's great.
I don't think things that we truly understand yet.
Yeah. Thank you for sharing these beautiful cases. Thank you for all your knowledge. And I just want to share a very last slide where I thank my fellows. They post in our very colorful doors that we have at the Pediatric Retina unit. And I invite everyone from the audience to really come and have the opportunity to see what we have done thanks to the APEC work and a lot of donors that put a lot of money, a lot of effort. And we are aiming to do what Bascom Palmer does, and we need a lot of support, and this is really happening. So we have this area that is totally, we have a colorful, very Mexican design where we have, even the designers were part of the donation. And we, now because of COVID, kids are not playing here, but they really make a lot of entertainment before going into their appointment. We have an area for breastfeeding, which is amazing for moms. And we are next to the genetic department. So we're finally working together with them. We have patients, they come again to us and we discuss. We have done EUAs where they do skin samples and they do biopsies. And so we work together as a team. And we have this area because in Mexico, we need kids to be transported from their original hospitals to our centers. As you see, we have NICU babies here, where this is the only place where they have their eye exam, and we have offices with regular size for big kids, but we also have an office just specialized in kids, and we have everything portable, and we're here together in all the specialties, and we have an area where we do sedation. So if we need a baby to get sedated just that day, just for an EUA, or we want to do a procedure, something that doesn't need the vitrectomy or something for intraocular surgery, we just go there. We have a RETCAN, we have an OCT, we have a UVM, we have an A-scan. We're basically fully equipped, and we're very proud of it. And I hope you can come and join us to meet this.
and easy.
And don't forget to come to October 6th to our session on intraocular tumors in pediatric patients. So I don't know if there's a last comment for everyone to share.
Just one thought. Nina and I talk about you, Linda, and Carolina very often. And the truth is, in such a short amount of time, you two have built such a beautiful practice. And we see your videos, we see your outcome, and we're both very honored to be a part of your training, and we are incredibly, incredibly proud of what you have accomplished.
And on that same note, you know, there's nothing better than being able to do something and see somebody else do it and do it sometimes even better. So congratulations to the two of you. Lovely.
Thank you. We're getting older, by the way. This is just getting us older.
Pediatric retina ages you, okay?
Not as much as glaucoma. Yeah.
That's true. Yes.
Well, thank you, Juan, for being here and supporting all your knowledge is very valuable. Dr. Mendoza, thank you for your passion on this, for making things so complicated to look so easy. That's a very important trait. Dr. Brocal, your experience and your, honestly, the way you always think on function and on moms, that's unique. And it's just the same school that Dr. Peters has. That's why you work together. Thank you, everyone, and see you in October 6th.
And we'll continue.
Carolina, see you tomorrow.
Linda, see you tomorrow. Have a great night. Thank you. Thank you so much.
Thank you, family.